All right, so one of the things I enjoy talking about is patients with stroke. A number of years ago, I worked down in Georgia, as I've shared with you, and my partner at that time, he was a brand new paramedic, one of the smartest medics I've ever known. He asked me, and he said, "Why do we run emergency out to stroke patients, and then even when we get there and we see that they're having a stroke, we run non-emergency back in?" And my answer was, well, if we get there and they're having a stroke, there's really not much that we can do about it. We run emergency out because sometimes patients or callers misunderstand some of the signs and symptoms. Maybe the information doesn't get relayed to the dispatchers accurately, so we're not entirely sure what we're getting into when we go out. But now that has changed. There's a ton that we can do to help to identify and treat stroke, and it all begins with you as EMS responders. Now, what I want to do is I want to take just a little bit of time and talk about some of the anatomy and physiology of the body. The brain is what makes us who we are. It's about a 3 pound organ that needs a constant supply of glucose and oxygen. Certain organs can store glucose, in particular the liver and some of the muscles can store glucose to pull out later on when the supplies get low. The brain cannot. Now, there's no organ that can store oxygen, so everything is going to need a constant supply of oxygen. But those are the two important things that the brain needs to be able to function. Now, fluid is important because when we get dehydrated, we can have an altered mental status along that line as well. But those are the two things that are critically important for good brain function. Even though the brain only makes up about 2% of our body weight, it consumes about 25 to 28% of the oxygen and the glucose that is introduced into our body. The cerebrum is what makes up the majority of the brain, and that is basically this part right in here. Now, at one point in time, it was thought, well, we only use 10% of our brain. Has been proven to be false. We use all of our brain on a daily basis. And one of the interesting things is when you were born with all of the brain cells that you're going to have. When brain cells die off, they do not regenerate. Much like in the heart, when heart tissue dies off, it doesn't contract, it does not conduct electricity. When brain cells die off, they don't do anything either. Okay. Now, different things affect us. It is throughout our life, whether they're positive experiences or negative experiences, this helps to shape how the brain works. And one of the big things that researchers are looking at right now is the role of trauma and its impact on the brain, both from a physical perspective, as if when you're having physical trauma, or psychosocial trauma and the impact that it has on a person as they're moving forward. Now, the brain is divided into two sides or two hemispheres. You have a left and you have a right. Basically, the structure from the left to the right is pretty similar. So that's what it means when it is symmetrical. The thing to keep in mind is that when the body is working, the right side of the brain controls the left side of the brain controls the right side. Everything comes into the brain and then it crosses over as far as the impulses to affect whichever type of part of the body that is coming into play. Now, the left part of the brain controls speech and language. So if you've got a patient that has a stroke and they're beginning to have trouble speaking, maybe their language is, their speech is slurred, maybe the words that they're saying are coming out completely jarbled or in an improper order, we can be fairly sure that the stroke is taking place over on this particular side. Now, we'll talk more about this in just a little bit. But one of the things to keep in mind is that when a patient has a stroke, if they're having trouble talking to you, do not immediately assume that what you say they're not able to hear and to understand. Many times, stroke patients are able to do just that. So, Travis, you want to be you want to continue to be very compassionate and be very professional when you're dealing with these types of patients, primarily because in most situations you would not say things to a person that's awake and understanding in front of you that would be rude. And you guys are not rude anyway. You've been a good class this semester. But the thing is, understand that whatever you say, most of the time, stroke patients, not always head trauma patients, but stroke patients will be able to understand and to process what you're saying. Now, there are some words that you need to know. Okay, aphasia, APHASIA. Aphasia is the inability to express oneself. Okay, now there's two different types of aphasia. One is called expressive aphasia. I'm not able to communicate with you very well, but my brain is working just fine. So if you say something that you're making fun of me, if you say something rude about me, trust me, I'm going to be able to remember that and to process that. Okay, so that's expressive aphasia. Receptive aphasia is when you're saying something and I am not able to understand it. Okay, so in a stroke, a part of the brain has been impacted, and again, there's two types of strokes, and we'll talk about this in just a little bit. But in that situation, whatever you're talking about just comes across to me as a foreign language. So you may be talking to me in English. We may have a good friendship, we may have a good relationship, but what you're saying to me just does not make sense because my brain is not able to understand it. Right side of the brain basically controls what we're able to see and what we're able to hear. The right side of the brain also has a tendency to be the creative side. The left side has a tendency to be the logical side. I'm not going to ask you about logic and creativity in that regard, and I'm not even really going to ask you to remember as far as, okay, left side is visual, right side is auditory. But what I really do want you to understand is that this whole ability of being able to process information in the presence of a stroke comes about because we have a blockage or a bleed that's going on. Now, another term that I want you to know is called spatial skills, and spatial skills basically is the ability to understand shapes or forms or spaces. One of the things when a person goes in and they're concerned about having some type of dementia, they'll put them through a battery of tests that last the better part of a day. But one of the things that they do is a very short test, and what the physician will do is will say, "Draw me a clock, an analog clock, and I want you to put the hand so that it shows 3 p.m." Okay, and if a person has got the part of their brain, particularly on the right side, that is not able to process that whole form or that picture of a clock, the numbers could be anywhere. They could be going, instead of going clockwise, they could place them counterclockwise. They could put them all at the top or at the bottom or one side or the other. Or they could potentially put the numbers in the right way, and now instead of drawing the line, the big hand up at the 12, the little hand over to the 3, they do that and they draw the big hand down at the 6 and the little hand over to the 9. So that is spatial skills that now begin to be impacted. Now, there's a number of regions of the brain, In particular, two that I want you to be very familiar with. One's called the prefrontal cortex. The prefrontal cortex is where we make decisions. The prefrontal cortex begins developing in utero and continues to develop up until, and this depends upon your gender, ladies, your prefrontal cortex is fully developed at about 18 or 19 years old. Gentlemen, our prefrontal cortex does not fully develop until we are probably about 23 to 25. Seriously, this is one of the reasons why they theorize that women live longer than men, because they begin making good logical decisions at an earlier age than we do as gentlemen. Not a sexist statement at all. It's simply biology. So the prefrontal cortex is what helps us to make decisions. When it is damaged, we make bad decisions. Story is told about, I can't remember his last name. First name was Phineas, but he worked on, say it again?
Phineas Gage.
Phineas Gage. You know exactly who I'm going to talk about. Phineas Gage, who worked on a railroad back in the 1800s, early 1900s, and he was tamping down some dynamite with a metal bar, and it exploded, and it went up in through his head, and it took out part of his prefrontal cortex. Prior to that, they say Phineas Gage had been a good worker, good husband, good father to his children, but after that happened, his personality changed dramatically. He wasn't able to keep a job. He became very angry, as you can imagine one would be. He was prone to outbursts. Anything that you remember that I didn't?
He was a drunk.
He was a drunk. You're exactly right. So he was, he wasn't an alcoholic or a drunk prior to this accident. And so this was one of the very first times that they were able to study a person and the changes that come about as a result of physical brain trauma. When we're talking about stroke, we're not talking about physical brain trauma, but we're definitely talking about medical brain trauma. The end result here is brain cells die off. And when brain cells die off, it has a detrimental effect on our patient. Prefrontal cortex, decision making. The other thing I want you to be aware of is your brainstem. Brainstem controls what are known as the vegetative life functions of the body. It helps us to sleep, or it helps us to breathe. It controls our heartbeat, and it does have some control of our digestive processes. When the brainstem basically dies off, the patient dies off. And many times in situations, especially in situations of physical trauma, we get an increase in the pressure in the side of the skull called increased intracranial pressure. And at some point in time, the brain begins to extrude or herniate. There's really only one place in the skull that brain begins to increase the pressure because of fluid, blood, or other things going on. There's only one place that it can go, and it's through a tiny hole in the back of your neck. It's a little bit larger than your thumb, or the back of the head, known as the foramen magnum. Foramen magnum. And again, as I repeat myself, it's not because I'm old and forgetful. You'll probably see that on an exam somewhere. The brainstem sits just up above the foramen magnum, and as the pressure begins to go, it's kind of like the old toothpaste tubes. When you squeeze it, it squeezes and it pushes the foramen magnum, or pushes the brainstem down through the foramen magnum. What that does is it causes direct trauma to the brainstem, and in many situations, your patient goes into respiratory and shortly thereafter cardiac arrest. So again, prefrontal cortex, decision-making area. Brainstem controls the vegetative functions such as the heartbeat and breathing for our patients. Now, for the most part, we're all awake in here. I would say, based on how busy you've been. I know Catherine worked at FDIC, maybe some of the others of you did too. I didn't have a chance to see you, and so you're tired. So your level of consciousness is not at its peak. This is probably pretty true for most everybody on a Monday morning. But when we're looking at this, it requires two things for us to be able to be conscious. One is called arousal, that's being awake, and the second is called cognition. That cognition is actually what makes us who we are. So when I look at this young man right over back in here, I'm awake, so I have the ability to look at it. And because of our interactions, I can recognize that this is Travis. Okay? I know what Travis looks like. I know what he sounds like. And so that cognition, or that ability to put all that information together, to put it together to come with that identification of a person, is that whole cognition that's coming into play. Cognition is actually defined as the ability to think, to learn, and to understand, as well as to remember. Many times this can be negatively affected during a stroke. We definitely know that as time goes by and you get older, your ability to remember begins to be hampered a bit. I'm at that age where I'm beginning to experience that myself. I don't have any type of dementia. Don't have anything to worry about that. I went to see my doctor because that was concerning. I'm a teacher. I got to remember certain things. When I sat down and talked with him, he said, "Bill, we're just both getting older." And that's exactly what your problem was. And I went, okay, I can deal with that. All right. And so what we want to do is we want to maintain that ability to have cognition for as long as we possibly can. Now, when we're looking about this, there are certain ways that we can use this to our advantage when we're doing a patient assessment. We can check our patient for person, place, time, and event. And we can do this by asking questions that they should be able to answer rather quickly. It's kind of like, well, sir, tell me your name. And you're able to respond back. Now, if I don't know you, I'm going to need to have somebody there to confirm that you really are who you are. Then you can ask them, can you tell me where you're at? Okay. And we're looking for kind of the global type of perspective. So if I were to ask Travis again, okay, tell me where you're at. And if Travis were to say, I'm at EKU, that's fine. I would not want him to necessarily expect him to say, well, I'm in Stratton 153 in a class. But if you can tell me I'm in a building at EKU, that's perfectly okay. Time. Now, here's the thing where it's got to be really careful about when you're assessing a patient for their ability to know what time it is. Close counts. All right. So if a person looks at you and says, well, I think it's like 10 or 11 o'clock, that's close enough without looking at their watch. Now, here's a little caveat. Don't ask a person who calls you in the middle of the night what time it is. Because, again, if you think about it, if you get awakened in the middle of the night, you don't even know what time it is. I have my phone next to my bed, and I've got it obviously set so that the light is off. But when I wake up in the middle of the night, I have no idea. I lean over and look at my phone, and I see what time it is, and I turn around and I go back to sleep. So just simply keep that in mind when you're assessing a patient. Just ask them, can you tell me, is it daytime or nighttime? They say nighttime, and it is indeed nighttime. We're good to go. And the last thing would be event. And under the event, quite frequently, what we'll do is we'll say, can you tell us who the President of the United States is? And so people should be able to answer those fairly quickly. If it takes them much longer than 10 or 15 seconds to give you an answer on that, that's an important finding. We don't know exactly why they're taking that much time to do it, but that is important. Now, again, remember, arousal means what? What does say arousal means? Cognition means the ability to think. Arousal means what? Just being up and awake. You're exactly right. In order to be up and awake, you got to have a good functioning brainstem, again, because it helps to control some of that as well. When we are assessing our patients for altered mental status, understand that these are some of the things that you can see. One of the things that I've gotten onto a soapbox about, because I've been doing a lot of lecturing, I've got a presentation that I give at different conferences that's called Just a Song Before I Go. Song put out back in the 70s by Crosby, Stills, Nash and Young. And this session that I use is all about the pathophysiology of shock, because shock fascinates me. But one of the things you got to remember is that anxiety is very insidious and very sneaky. Anxiety could be a normal reaction to where the sympathetic nervous system has just taken over and you're nervous, you're scared, you're anxious. Somebody comes in here with a gun, we're going to be anxious. A snake crawls across the floor there. I don't know about y'all. I'm going to be anxious. Look it up. It's biblical, okay? And that could be the potential thing, just basically of something scares us and we get anxious. For some of y'all, if I told you that in order to pass this class, you had to give a 1-hour lecture in front of 100 people. Just like that right there. Yeah. So you may feel, oh, I can't do that. So your heart rate goes up, your respiratory rate goes up, you get a little clammy, but that's normal. Here's the dangerous part. Anxiety is also an early, but subtle indicator of shock. It could also mean we don't have enough blood that's going to the brain. Okay. And so this is one of the things, like if you'll remember earlier on, and we talked in this class about if a person looks at you and they're having chest pain and you feel like they're having a heart attack and they look at you and they say, I'm going to die, aren't I? That's a type of altered mental status because their brain is not getting enough oxygen. Okay. So assess your patient really closely if their only symptom is anxiety. But we can see all these other changes that come into play. Their behavior could be just weird and bizarre. That's easy to see. They could be confused. When you ask them who the president is, they respond Abraham Lincoln. Okay? And so that's an indicator that I got to dig into this and look further. Change in higher cerebral functioning. So basically what that means is they're unable to identify who they are, okay? And then everything going on down through change in memory, in attention. We see a change in attention really frequently with head injury patients from trauma, because invariably, and you'll learn more about this in vast trauma, in a head injury patient, quite frequently, what they'll say is, Catherine, what happened? And Catherine's taking care of me, and you had a wreck. Was anybody hurt? No, just you. Am I going to be okay? We're going to take good care of you. Right now, everything looks good. 30 seconds later, it's like the old Etch-a-Sketch. Google it. You'll find out what it is. Everything's been erased. And it's got, Catherine, what happened? You had a wreck. Is anybody else hurt? No, you're the only ones hurt. Am I going to be okay? And that continues and continues and continues. Now, that could be a short-term thing or that could be a long-term thing. But that's really frequent with patients with closed head injuries. And as we talked about just a minute ago with Phineas Gage, and thank you so much for reminding me of his last name, that you begin to get these changes in judgment because especially the front part of your brain, the prefrontal cortex, has been damaged so that now we no longer look and can take information in and say, this is probably not a good idea for me to do. One of the key things that you want to do for your patients is get a baseline on your patient's mental status. This is often difficult to do if they already have a history of dementia or Alzheimer's. So what you have to do is, and again, this is one of the key things why it's really important that to your best ability, you got to get the patient's family on your side because they could be your best friends or your worst enemies. And so, in essence, what you need to do is you need to find out from them if this person is already in what I would say a persistent vegetative state. What is different tonight about their level of consciousness that caused the family to request you to come to the house? How are they acting differently than what their normal is? Because their normal is not going to be up walking around reading books, writing notes, or writing letters. They may just be sitting there making different types of noises. So find out what their baseline is, what is normal for them, and then find out, if this is critical, when was the last time that they saw the patient at this normal status? Now, this is really important, guys, because in just a little bit, you're going to learn how this is going to determine what you determine as the last known normal is going to have a huge impact on the course of what treatment the patient gets and what they don't get. I'll explain to you more about that a little bit later on. In getting your patient's history, always assess for allergies because we want to find out, have they done anything? Have they taken anything? Have they been exposed to anything that would cause an allergic reaction in them that may have caused this? Or do they have an allergy to something that we may give them? Okay. If you're working in the hospital, we don't give antibiotics a whole lot pre-hospital. Helpful hint to know, Georgetown does for open fractures. They will give a dose of an antibiotic prior to going to the hospital. And what they're finding is not only speeds up the healing, but it also minimizes the possibility of getting a bone infection, which is almost impossible to clear up and can cause the patient to lose their extremity. But if they're allergic to that, you need to know that because we don't want to give them that medicine if they're going to have an anaphylactic reaction. The other thing we want to find out is, what are your medicines? What medicines do you take as a patient? And the second question is very similar to that, is are you compliant with those medicines? Compliancy simply means I take the medicines the way that I'm supposed to, no more and no less. As patients get older, or sometimes as they get confused, they can do accidental overdoses. So they may be taking a beta blocker, and a beta blocker is basically to slow the heart rate down. They take it in the morning, and it's kind of like, I don't remember I took my beta blocker. An hour later, they'll go back and take another one. And then maybe an hour after that, they think, I didn't take my beta blocker. Now, an hour later, they go back and they take another dose. So they've taken 3 times the amount of beta blocker. And that's why when you get there, their heart rate is in the 30s and they're confused and they have a blood pressure that's, down in the toilet. When we're looking at this, find out, has the patient been ill or hospitalized recently? This is critically important because, again, let's say this is a cardiac class, but let's say that you're assessing your patient and the family says, oh, he had a stroke about 6 weeks ago. And in that situation, we're going to want to find out, well, what kind of stroke was it? Was it caused by a clot, which is called an ischemic stroke? Or was it caused by an aneurysm or an artery that ruptured in the brain? It's called a hemorrhagic stroke. What drug would be the last drug we would want to give these patients if it was a hemorrhagic stroke for a cardiac patient? Aspirin. Yeah, good job. Aspirin. Why? Because at 6 weeks, that artery is probably not completely healed up. And if the pressure's up and that artery ruptures and we've given them aspirin, guess what we've done? We've probably killed that patient, okay? And I call those PADs, paramedic-assisted deaths. And you don't want to do that. You don't want to do that. You're much better at that. So find out what their previous history has been. Take a moment when you're walking into the house or in the car, wherever you find your patient, and look at the environment around. Look for bottles. Look for needles. Look for things that give you an idea of what the patient was doing previously to you getting on the scene. There's two reasons for this. Number one is it will help you to come up with a working diagnosis for your patient. Number two, and I consider it as important or more important, is I want every one of y'all to be able to go home to your family at night. So looking for things that could be used as weapons if your patient, number one, is just a mean, bad person, or number two, if they're normally a good person, but again, if they've got some head trauma going on, whether it's actually caused by direct trauma or by a stroke, your patient may react entirely different and view you as a threat and try to hurt you. Again, the last bullet on here says, look at and talk to your patient's family. They are your secondary patients. So treat them with respect, treat them with compassion, because in most situations, they're very concerned about their loved one. That would be a normal reaction in the case of an emergency. And so if you can't get information out from your patient, they may be the ones that you're going to have to get the information out from. So these are some of the things, again, that you would see that would be changes in brain function. They're confused. They're not able to remember things. They have some amnesia, and you can have retrograde amnesia, which basically means that I don't remember things in the past, or you have anterograde amnesia, which would mean, well, yeah, I used to know you. I can't remember what your name is now. And so they have that present forgetfulness that's going on. So retrograde is things in the past. Anterograde is what's happening right now. Unable to be oriented, okay? The orientation that we're looking at is person, place, and time, all right? And those are the things that we're looking at in going there. Other things that would tell you that there's probably something going on would be their ability to walk. So if a person staggers or if they're not able to stand up without help, there's something that's happening up in the brain that is messing with their regulatory mechanisms that would allow them to be able to maintain their balance and to function like a normal person would. So when we're evaluating thought and speech, one of the things that I like to say is sometimes I have lots of thoughts up in here, but luckily on a daily basis, I try my best to have a filter placed between my brain and my mouth so that not everything that I'm thinking comes out. So, for example, my wife and I went up to Canada one time and we were driving across the border, and the guy looked at my driver's license and wanted to know, he said, "Do you have any weapons in the car?" And I said, "No, sir, there are no weapons," because I know you can't take any weapons into Canada. So he stood there for about 30 seconds and looked at my license again, and he looked at me and he said, "Are you sure you don't have any weapons in your car?" Well, me being the funny guy I try to be, my first thought was, well, what are you looking for? Luckily, I didn't say that. I didn't say that because I can imagine being in a Canadian jail. I just simply said, "No, sir, I don't have any weapons. If you would like to look at my car, you're more than welcome to do this." So he handed me my license and we moved on. So again, that ability to not let your thoughts leak out of your head is critically important. Patients who have head trauma, whether it is medically induced or trauma-induced, often lose that ability to keep things in your head. One of the things is it's a phenomenon that I've noticed is that often people who normally that you would know, and if you're working in a small town, you're going to know a lot of the people that you take care of. But people basically who are kind and compassionate and gentle and would never ever speak a swear word or anything along that line, if they have a brain injury, their mouth just runs off. I mean, just with the most filthy words. I can remember when I worked in Jellicoe, There was a man down there that I had known for years and years and years. He was the father of the chief surgeon that worked there at the hospital where we were based, and just a good guy, nice guy, compassionate to everybody. And he had a car wreck, and he has sustained a brain injury. And this guy said words that I would never have ever imagined that would have ever come out of his mouth, and that's because his brain had been affected because of the trauma that kept that ability to keep those words in your head and not out. The other thing is there speech on target with what you are speaking about, okay? Or does it veer off to other things, and so this is important to find out because that means that they're able to maintain a certain amount of attention on what you're talking about. And then the last one on there in particular is, do they ask these repetitive questions over and over and over? That is often a dead giveaway that there's something major that's going on within the brain. And again, we see this with concussions, which is a temporary situation, or we can see this with people who have long-term brain injury. So basically, when we say alert and oriented, what does that mean to you? Alert and oriented.
Well, if you're alert, you're responsive. You're paying attention. You're here.
Okay. And oriented?
You know where you are.
Okay. Good. Now, here's the thing to keep in mind, you cannot be alert and oriented and not be awake. However, you can be awake and not be alert and oriented. All right? If you don't believe me, take an 8 a.m. class and look at the people in class on a Monday morning at 8 a.m. Okay? And so you can be awake, but nothing is beginning to process. And again, what we're looking at here, I've got A&O times 3 or A&O times 4. Any of them, at the very minimum, A&O, alert and oriented times 3, would be, do they know who they are? Number 2, do they know where they are? And number 3, do they know the time that it is, both the hour time and the date and the month? Now, times 4 would be, are they alert to the event? Do they remember what happened? Okay. Quick story again. I was doing a paramedic program site visit down in South Georgia. I was riding my motorcycle and came back. Short story is that I was getting ready to get off of the exit, and the next thing I know, I wake up in the back of a helicopter. I'd wrecked my motorcycle, car pulled out in front of me, I laid it down, and I had gotten a minor head injury. To this day, I don't remember that event. I only can go on what people tell me. And so that's an important finding when you are sharing or doing your assessment of your particular patients. When we're looking at this, we want to look at levels of alertness. And in particular, the one I do like is AFPU. A, alert, V, verbal, P, painful, and U is unresponsive. Basically, alert is, for the most part, the way we all are right now. It's a Monday morning. It's actually a Monday afternoon, but I understand. So we're awake. We're able to process things. V is the patient is unresponsive, but when you call their name, or if they say, hey, you, they wake up and then they may stay awake for a little bit of time and then they descend back into that unresponsiveness. P is they respond to a painful stimulant. Now, again, do not cause trauma to your patient. Something as simple as just simply rubbing your knuckles across their sternum, pinching the trapezius muscle, or just kind of touching the eyebrow, or not the eyebrow, but the eyelashes with your finger will help you to determine whether they respond to that or not. And then U is going to be unresponsive. The GCS we'll talk about a little bit later on. I'm not a big fan of GCS, but it's an important thing that you'll need to know as well. In the body, we have 12 cranial nerves. Now, a lot of paramedic programs focus in on making you memorize the 12 cranial nerves and what they control. I got some good news for you. We will not be doing that in here because that's something you can look up, okay? Inevitably, what happens is you memorize the 12 cranial nerves, and about 20 minutes after you finish class, you do a brain dump and it's gone. So the thing I want you to understand about the cranial nerves is starting up and working our way down now begins to affect different things within the body. And then the last thing that we've got in here is your gait. What you want to do is, if your patient is able to stand or walk without assistance, have them walk. Have somebody go alongside them, because the last thing you want to do is have them fall and hit their head on a table or fall and break a bone in an extremity. But you want to see how they're able to walk. Law enforcement officers do this all the time. When they're doing a field sobriety test, they'll ask a person to do heel to toe as they're walking across. For most people, that's not going to be a problem. Some people do have a problem with their balance, and if they disclose that to the officer should take that into consideration. But if they're using some type of illegal substance or even an illegal substance in an illegal amount, that will affect that. Again, as far as when we're looking here at AVPU, the big thing that we're looking at is alert. Your patient knows where they're at. They know what's going on. They may or may not remember the event, so we kind of push that off to one side, but they're alert. And again, like I said, remember, you can be awake and not alert, but you cannot be alert and not be awake. V is the patient's going to respond to verbal commands. Now, the thing is you may not know the patient's name, but if you do, utilize it, okay? And you ask the patient to do something when you do that. Most of the time it's kind of like, James, open your eyes up for me, okay? They open up, you stay awake. Watch what they do when they open up their eyes. Normally what would happen when a person wakes us up, especially if it's a person that we're not familiar with and we don't know, our eyes would go to that person. But if you got a patient that's got some type of a brain trauma that's going on, and again, I want to stress to you, when I talk about brain trauma, I'm talking about either physical trauma, getting hit in the head, struck in the head, shot in the head, or medically caused by like a stroke. Many times they'll open their eyes up and look straight ahead, and they never move that. And then that's an important finding for that particular patient. P is response to painful or tactile stimulation. Again, whatever you do, do not harm your patient. You will be guilty of battery, and you can go to jail. Understand this, guys. And I'm not going to speak to any of the recent cases that involve paramedics, but you, as a paramedic, are no longer made of Teflon. It used to be, as a paramedic, as an EMS responder, it's kind of like, oh, they're the good people. We can't charge them. We can't sue them. That is gone, and it's not coming back. You can be charged and sued, and people will do that just as quickly as they will with law enforcement, with fire service, or anybody else. And so the last thing you want to do is put yourself into a position of where you deserve that. So I give you that as far as the P for painful stimuli. It's basically just simply use it as an uncomfortable thing. Grabbing hold right here, not a good feeling if you're not expecting it. Same way with a sternal rub. And the last one is your patient is unresponsive. They just don't move whatsoever. Now, I'm going to stop there, and we will pick up with the rest of the lecture